I would like to show you a case of a patient. It's a 30-year-old woman that presented in the office with a failing lateral incisor in the anterior region. And you see on the picture it's the left lateral incisor, and on the X-ray you see a failing root. We were not able to restore this root anymore with the crown, so we planned to take it out and in the same session place an immediate implant. And today we are able to restore these teeth immediately, and we fabricated this kind of shell provisionally for the session. And you can only place these kind of immediate temporary restorations when the implant has an insertion torque of over 35 Newton centimeters. So today the surgical concept of immediate implant placement always try to avoid to raise a flap. So we don't raise a flap, we place the implant and we do the drilling in the palatal wall of the socket and then try to engage the implant in the palatal wall. So in this case we placed a BLT SL active implant of a diameter of 4.1 and length of 14 millimeters, and we had a primary stability of over 35 Newton centimeters. And here you see the lock sim, and you have the control of the insertion depth with these little notches you can see on the picture. And I always try to insert the implant 3 to 4 millimeters beneath the soft tissue margin I want to achieve. This is the end of the surgery. You see we placed this temporary on the implant, plus I placed connective tissue graft, which are inserted under the soft tissue between the buccal plate and the soft tissue. And I have to emphasize, you can only carry out this kind of immediate implant protocols when the buccal cortical plate is present. On the right picture you see the healing after 3 months, and this was the day when we took the impression of the implant, and you see nice healing. We fabricated a crown. It's a zirconia framework that we bonded on this titanium base, and of course we have here the dental veneering porcelain. So whenever it's possible we go for screw-retained crowns today, because we want to avoid excess cement that is causing maybe peri-implant inflammation. So whenever possible go for screw-retained. Here you see the healing, and actually we have now a follow-up of this case of 1.5 years. And the patient is very happy with the result. We have an aesthetically pleasing result. We don't see any inflammation or signs of inflammation of the soft tissue. If you take a look at the X-ray, we see this is when we started with the failing root. This is the end of the surgery with the temporary in place, impression taking, and here you have the final crown, the final restoration, and you don't see any signs of crestal bone resorption. You have perfect conditions. If I summarize, I have to say we have a very nice macro design, or let's say shape of the implant, because it allows for high primary stability, especially for immediate implant cases. But in my office actually I use this implant for almost all the indications I see. Plus we have the SL active surface, which guarantees for a fast bone response and bone healing. And for me, my concept for the restorative part, I'm happy to have a titanium base, because then we're free, or let's say the technician is free to work with whatever material he wants to. He can use zirconia or can also use lithium disilicate, because we have this titanium platform we can work on. The patient was very happy with the final result, and so was I, because we don't see any resorption. We see soft tissue stability, we don't see any kind of inflammation. And for example, this patient, which was a pretty young woman, it was very important for her to have fixed teeth from the first day. So she never went with a removable denture or anything. So yes, she was very happy with the result, and also with the comfort we were able to give her during the whole procedure.